Okay, welcome everybody. I think we'll go ahead and get started. Thanks for coming to seminar today. We'll have to thank Elizabeth for the food. It looks pretty good. I'm waiting to dig into that. How's it taste? Good? All right. So we have a couple different speakers today. I think some of you have been around a while. Will remember both Cheryl and Randy came and spoke to us, I think it was about 3 years ago. So Cheryl is the Vice President of the Midwest Business Group on Health, which is located here in Chicago. It's a group, a coalition of employers that gets together and then focuses on healthcare issues. And she's going to give a little bit more background on what the group does and her role and so forth. Randy has a long sordid history in pharmacy and healthcare and managed care and specialty drugs and everything else, and he's got multiple titles. He has a PhD, and he's also a pharmacist, and he's the principal of a consulting group, the Institute for Integrated Healthcare. And he's been working, I think, for at least 7 years, it sounds like, with Cheryl and the Business Group on Health. And he talked a little bit about some of what he was doing last time he was here, and he's going to give us an update on some of those things, but also a lot of new information and projects that they're working on. And I think, importantly, some opportunities for us to get involved in what they're doing, both research-wise and some publications. So I think, is Randy or Cheryl's going to start? Okay.
Hi, everyone. We're excited to be here because we all live in our own little silos. This is the academic world, but you guys are doing things that are part of our project. I live in a silo, but that silo forces us to understand what other stakeholders are dealing with. So to start out real quickly, I'm going to tell you a little bit about MBGH, and then the rest of it we're going to focus on the National Employer Initiative on Specialty Drugs, which is a research project that Randy and I have been working on for about 7 years. The Midwest Business Group on Health is an employer coalition of human resource health benefits professionals from companies like Kraft and Boeing, the city of Chicago, the state of Illinois, and employers, self-insured employers. Who knows what a self-insured employer is? Okay, so the difference between self-insured and fully insured is I'm a self-insured employer and I'm choosing to take the financial risk for the medical and pharmacy claims. I'm willing to pay for them because if I do it that way, I don't have to pay a health plan and I'm going to save money. Fully insured are small employers that can't afford to take that risk. We represent, and so the health plan covers everything. They take the risk for everything. We only represent self-insured employers, the ones that are actually paying the bill. And in our world, health plans and PBMs, pharmacy benefit managers, are not the payers. The employer is the real payer of healthcare. Healthcare costs, healthcare benefits, and they're designing those on their own. So they have an invested interest in working with their the stakeholders, the vendors, the health plans, and making them accountable. We're going to talk about that a little bit today. So we're a 501c3, which means we're a nonprofit that doesn't lobby or legislate. We focus on research, education, and many other things. And this is it is our largest research project and one of our oldest research projects. And Randy and I co-lead that initiative. So just to set the stage, here are some fairly recent stats about biologics and specialty drugs. By 2018, specialty drugs, and when I say specialty drugs, I'm talking about biologics as well. By the way, I'm from Chicago, I talk fast. And I only have 15 minutes. So sorry, don't complain on your evaluation if you have one. By 2018, specialty drugs will account for about 50% of all drug costs, and that's going to go higher because one of the biggest problems with specialty drugs is a lot of them run through the medical benefit. Some run through the pharmacy benefit, some run through the medical benefit. If they run through the medical benefit, so a lot of your oncolytics, your drugs for rheumatoid arthritis, your drugs for MS, anything that's infused is going to run through the medical benefit, and it's really hard for the employer to get a sense of what is being spent. It's one of their biggest frustrations. They usually have a pretty good idea of what's running through the pharmacy benefit. In fact, PBMs or pharmacy benefit managers would love to have more of the specialty drugs run through the pharmacy benefit so they could make more money, and we're going to talk about that more today. Look in the bottom right-hand corner. This is an actual employer graph that shows what the total claims costs were. Total claims, these little tiny gray bars at the bottom versus the specialty drug costs. Total claims versus just drug costs. They are anticipating that specialty drugs will cost 50% by 2018. By 2016, they met that number last year. They're over 50% of all of their total drug spend costs today. That number is going to continue to increase. They're representing half of all the new drugs approved by the FDA today, and the majority of the new drugs in the marketplace are targeting rare disease or orphan diseases and oncology. First, biosimilars, as you may or may not know, which are not generic versions of specialty drugs or biologics. They are similar to them. They are not interchangeable. 4 of them are on the market. Prior to that, hemophilia and a few other ones were on the market. It's going to be a slow road. And ironically, if you've got an RA biologic that you've sent out, and you're going to try and, we had hoped to see 20 or more % cost savings, but the brand manufacturer that already has the brand drug that's been on the market for years, they're just lowering the cost. So that's not much is going to happen with that. We're going to see a lot of increases in the number of diagnostic tests, genetic tests, lab diagnostics. These are going to be necessary to make sure that the right drug gets to the right person at the right time, and that you're not prescribed something. There are stories of, an oncology drug that's very expensive being prescribed for a patient when it's not going to work correctly in that patient. So employers are trying to get the vendors that they work with to say, we want these tests done. But the plans often don't want to pay for them, or the PBM doesn't want to pay for them, so that's another challenge. Imagine we've got these dysfunctions kind of in the tree, or the roots of the tree, as I had earlier. And the roots just keep getting deeper and deeper because all of the stakeholders out there are trying to make money. I was just sharing with Glenn prior to our Professor Glenn, what do they call you? Glenn, okay. At least I got the name right. Employers pay for the majority of all health care in this country, and yet no stakeholder, not the health plans, not the hospitals, not the doctors, not the PBMs, not all the vendors that are out there, nobody wants to make less. And if we don't get control of specialty drug costs and a lot of the waste and abuse that's happening in the marketplace, if they exit health care, this whole system is going to fall like a house of cards. Right now they're covering more than 50%, as I said earlier, in some cases up to 70% of all health care. The government pays for the rest. And then finally, PBMs, or what we're also calling middlemen. So the middlemen in pharmacy benefits, there's lots of middlemen in health care and health benefits, but the middlemen in pharmacy benefits includes the wholesalers, it includes the drug distributors, but right now the biggest challenge we have are the pharmacy benefit managers, and that's who we're targeting as part of this initiative. And they're adding significantly to the cost of the drugs. There are so many stories I could tell you. We're not pointing them out. We know pharmaceutical manufacturers are already charging too much, but they have a right to charge what they want. It doesn't mean we as employers have to buy those drugs. We don't have to, but we have to control what we can control. Okay, moving down. There it is. We do a lot of research on our own. It's directional. It's not scientific or academic like yours, but we wanted to find out where large employers were at with this whole space, and at some level they're a little apathetic about what they can do with the PBMs and the health plans. They feel like, even though we represent employers that are as large as over 100,000 lives or 1,000 lives, their perspective is we're going to continue to offer benefits to make sure we can attract and retain the best employees in a competitive market, but cost trends continue in this specialty drug environment. We're going to need to make some changes because our goal is to provide high quality benefits to employees and families. So we're going to push the market to change use of measurable clinical outcomes as the driver behind use of prior auth, step therapy, and utilization review. By the way, employers, and you'll see it later, are still continuing to use traditional drug benefit strategies for specialty drugs, and that does not always work. So we're trying to educate and empower them to start looking at other options. And right now, we know that formularies are not built on the best drug. Formularies are built on how much that PBM makes on a rebate. Dirty little secret, I see a lot of heads bobbing, but I go to employer conferences and I see jaws drop by employers who have no idea about what's really going on. They want to make sure required pre and post testing is happening to make sure that it's the right patient, right drug, right time. Quality adherence programs, a lot of the PBM and health plan programs out there have not focused that much on adherence. There's no performance-based outcomes in their contracts. There's no desire for them. They want to sell everything up. So we're trying to educate and empower employers to be changing their contracts to get better accountability, cost savings, and patient outcomes out of them. And then finally, standardization of care, and we talked about outcomes-based utilization. Here is my other comment about the middleman. So we as self-insured employers have a fiduciary, by law, fiduciary responsibility to members, to plan members, that we're going to provide the best quality, best benefits at the best cost. But we know that most employers are relying on these vendors, the PBMs, the employee benefit consultants, the brokers, to help them manage their drugs. And by the way, even though it's illegal to pay for a PBM or a vendor to pay somebody under the table to drive business their way, it still is happening. Benefits consultants are still getting paid under the table to regurgitate the same PBM over and over and over, and the employer doesn't know that. And they might have paid $50,000 for that RFP to take place, but it's the same vendor they're always recommending, or one of a handful. Middlemen, as we've talked about, are adding to the costs. PBMs continue to lack transparency for pricing, rebates, and contracting. In fact, we're seeing some employers who are saying, I'm trying to use the knowledge and education you've given us to change the way we contract with PBMs and other vendors, and they're refusing to accept our contracting terms and telling us to move on, that they don't need that business. So it's kind of a scary environment that we're in right now. We believe that employers need to recognize that if something isn't working, it needs to be paid for differently, and that's part of what we're going to talk about today. Here are some key highlights from our annual member survey. We've done 5 annual surveys in the last 6 years. We have large and jumbo employers across the country primarily that are completing these surveys. We work with a number of our sister coalitions to conduct these surveys. You'll see in this case, actually this is our annual employer member survey. My mistake, it's not our specialty drug survey. Managing specialty drugs comes in at number 1 for the first time in 6 years. Previously it was culture of health. It has been higher than culture of health, but complying to the ACA has been number 1 for years. Well, that's all changed now. And yes, I'm closing my mouth and not making any comments about Trump here. But managing specialty drugs is employers' number 1 priority. In our employer benchmarking survey that we do every year about specialty drug management, obviously cross-trend is number 1. We need some new and innovative solutions, and we're not seeing them from the vendor community. The next several options are really more vendor tactics, so prior authorization, quantity limits, number of drugs in the pipeline, limitations and exclusions. Some of these are driven by the PBM. We probably have too many regulations in place for a specialty drug benefit. There are times when you need it for a drug and times that you don't. And part of what you need to know is that PBMs and health plans make money on these services. So that's part of the reason, yet most employers don't know which ones should we use and which ones shouldn't we use, because this is the wild, wild west. There's all these different disease states. There's all these drugs within each of those categories, and then there's all these other options that are available out there. Rebates, they think, are critical to cost management. We want to get rid of rebates, and pharmaceutical manufacturers who started rebates as a way to get on preferred formulary status now regret that they did that. Just as employers started PBMs by carving them out from the health plan, they carved them out and said we want integrated care with all these different services, and 30 years later they realize they've created a monster because nothing is transparent. One of our goals, and Randy will talk a little bit about it, is to unbundle that jigsaw puzzle and try and put some of the pieces together. So you'll see most employers are still using same traditional plan design that doesn't work in a specialty drug environment. Most of them are also using vendor management guarantees in their contracts, but it's not based on things like are they adherent to their medication. It's more basic things, so we want them to be a little more aggressive. Employers adding a specialty tier doesn't always work. Shifting additional costs to employees, this is a huge problem, and it's going to be even a bigger problem with the full replacement of high deductible health plans, and then the new Trump Care talking about HSAs. I think HSAs are great if they're implemented correctly, but the majority of employers in this country are not sophisticated. They don't do a great job helping employees understand what the plan means and communicating it consistently. So that's going to be a problem. There's research from many entities out there showing that people in a high deductible plan are not getting needed care. They're not filling their scripts because they don't want to spend the money. And most employers are not contributing enough to those plans to enable the patient to get the drugs that they need. Using a narrow network that assumes the risks through ACAs and things like that is a growing strategy. Single benefit incorporated into the medical plan. So in other words, both your medical and your drugs are in the medical plan, and at least you get better reporting and better transparency instead of trying to integrate the two. When you carve out specialty, you got the medical health plan stuff, you got the pharmacy PBM, pharmacy benefit stuff. My favorite option, you see it at only 4% here, is one of my employers has no formulary. You can get access to any drug that you want. The hook is if it's a convenience drug, like Viagra or toenail fungus cream, that only benefits you as the patient, they're not going to pay for any of it. If it's a business-preserving drug, like for any of the chronic diseases or certain lifestyle risks or high blood pressure, diabetes, etc., they're going to try and remove financial barriers. If it's a life-saving drug, they're also going to make the cost as low as possible. By not paying for every drug, every Me Too drug on the market, they're able to afford the higher, remove cost barriers for these other drugs as well as specialty drugs. I think it's brilliant. I just wanted to share real quickly that this is what future plan designs are going to look like. Look what came up at the bottom. Employers recognize that traditional plan design isn't working, so it dropped to the bottom for the future. The idea of no drug formulary went from 4% to 49%. So you'll have access to these slides, interesting stuff. Look at this slide. I don't want to go into it because I want to get to our project real quick, but this is, we wanted to say to employers, are you aware of the growing number of docs that are on payroll with hospital systems? And so when somebody goes in for an infusion, they're paying the hospital rate, which is 4 to 5 or 6 times higher than if they went to the doctor's office that wasn't affiliated with a hospital system. Plans lack of payment to a pharmacist for MTM. We're looking at things that are affecting the stakeholders in the market and affecting patient outcomes. So here are some interesting slides there. Our project, a little bit about it, run by employers, driven by employers, 5 annual employer member surveys. If you'd like to learn a little bit more about what's going on the market, here's our website. It's available to anybody in the country. When we started this project and we've gotten it funded, we said every employer needs to understand what's going on in this space. We just relaunched it recently and we're adding additional information to it, but it's a great resource to look at. Here are some of the coalitions that we're working with across the country on the project. We're doing annual multi-stakeholder meetings because we cannot do this in isolation. Employers need to understand what they need to do, but we need to bring the other stakeholders to the table and have them be part of the solution for the future. New 2017-2018 work streams, we're going to be building an employer roadmap that helps an employer, whether he's just starting out or she is in the middle of understanding how to manage this but still needs more information, and providing case studies about what leading employers are doing. We believe very strongly about telling the truth about what's going on in the middleman space. So Randy and myself and a couple of our colleagues that are leaders in this area are going to be writing a white paper about the middleman. We're going to be marketing it in the media with our sister coalitions and letting people know the truth and giving them solutions about what they can do about it. We've tried for years to see changes in the market. There have been, so we're going to, Randy, I didn't say this, resort to shaming them. Okay. Data mapping is another area we're looking at. We're looking right now at RA, so you can track certain key areas in the rheumatoid arthritis environment. Here's a picture of the toolkit. There's a whole section on tools and resources that might be beneficial. Wanted you also to see what the key elements were that we focused on during the 5 years that we've done this employer benchmarking survey. We found that there was a pathway of lack of understanding and awareness about what specialty drugs even were. Certainly no clue about how to manage them that might be more progressive or innovative from traditional drugs. We found out that senior leaders had very little knowledge about what was going on in the space. And I always say, if you're an HR benefits person and you don't have access to the C-suite, or you don't have autonomy within your organization, you don't have a lot that you're able to do about this. So we've got to give you access to the services or the resources or the tools to know what to do. Here's my contact information. I'm probably about 30 seconds late. Thank you very much. Just click out of that.
All right, so you got some foundation from Cheryl, a little understanding of the world that we operate in. I got in to the employee benefit consulting world about 15, 20 years ago now. So I've been at it for a long time. It's unusual, and to still be surviving. And it's also unusual in that I do a lot of research. Most are only in what we call transactional services, which is in all the contracting elements with employers. So I do have the background in pharmacy. I do have the background in research. I get involved in a lot of different types of activities, which I'll be touching on. 3 particular opportunities I think that we could have in working with UIC. Another opportunity just in general, since you are students and faculty, I'm also on the editorial board of several publications. I'm also a column leader for a couple different publications. So if you're interested in doing something around employers and publishing around that perspective, get in touch with me. You can get through Glenn as well to me. So there are opportunities there. And I do work with several colleges, pharmacy and medicine around the country. So you'll be working with some other people as well that could be interesting. So what I'm going to touch on, even though I'm not from Chicago, I will talk fast because we do have to do this quickly because we want to have some time for Q&A, get some questions from you. So I'm going to build off of that theme of the knowledge gap that you just heard from Cheryl, as well as a lot of the problems that exist in the marketplace because the way that things really haven't changed as yet. So we have a lot of contradictional thinking and action that has been taking place. So understanding employers in the general context and how that begins to correspond to what we see day to day from a pharmacy perspective or a provider perspective. Some of the analyses, building again off of what Cheryl shared briefly with you, some of the data gaps and insights that we need to start looking at, which is part of the opportunities that I'm seeing now much more clearly, and some of the other opportunities that are related to that once you understand what's happening in the market. And given this change that's now underway again because of the Trump administration, is a tremendous opportunity in itself because the overall disruption that's happening in the marketplace. So one of the things I thought I'd start out with is coming in healthcare, and particularly from a pharmacy silo mentality that we all have been in or are currently in, you don't realize that there's lots of other things going on in other sectors of our economy. And healthcare is the last sector of our economy to undergo the kind of change that we went through with ACA in 2010, and we're going through now with the Trump and House of Representatives initiative. So this comes from the IT world, and it fits healthcare like a T. Because we're trying to figure out how we're going to sustain healthcare. We know it's unaffordable if we can continue on the path we're on, so we have to change. So from the IT world, and this is from 2015, from Health Management Technology, they talk about transparency, and I kind of did a little bit of adjustments in the adaptation to make it sound a little more like healthcare. But it's really stunning how similar in their verbiage it is, even though they didn't get techie about it. But patient engagement is important. It's going to be an absolutely critical factor no matter what comes out of Washington. Competition and compensation based on value. We hear a lot about value-based healthcare. We need advanced analytics, not just analytics, advanced analytics and predictive modeling. We see IBM in it in a big way with Watson. What's the biggest problem with Watson, which nobody talks about? It's great you have that computer power, right? But there's no data that helps them understand, is that really the right drug? Because we don't have good data around that drug that people share. So there's a lot of knowledge gaps that even a tool like Watson has. You want to put numbers in, it can punch out numbers real good and tell you which one's the cheapest option using formulas. So it's interesting that you think, here's the brilliant company with this great tool, Watson, but there's a lot of problems still with that, given where we're at in healthcare. The interoperability and decision support kind of feeds into that. There's a lot of gaps in the IT space around healthcare because we never really invested in it. We're not scalable still in our delivery models, and population health, quite frankly, is still a joke. I started in population health, working with the federal government, and Cheryl and I were talking about this at dinner last night. A lot has not changed during my career. That's pretty sad. And we spent a lot of time and money doing things in population health, and we're still talking about population health. Precision medicine and provider engagement, that's where this is all going. I'll touch on that a little bit later as well. But we have some great opportunities going forward if we take advantage of it. But it's going to need a lot of research support because of a lot of those gaps that I was talking about. And so a lot of that has been established in the IT space, and that's what you see Google doing and Amazon in the IT space. They're all kind of doing the same kinds of things. So we can learn from other sectors of the economy. So we want to understand the other purchaser. And Cheryl gave you a little bit about that employer as the other purchaser, and that was enabled back in 1974 with the passage of ERISA, which is the Employee Retirement Income Security Act, and it allowed employers to be self-funded. So they would assume their own risk, and they would fund their own plan. And then they would hire an administrator to manage and execute their plan design. So they would hire, for example, and this is one of the reasons why the merger of those health plans didn't go through, is a substantial amount of their business is as a vendor, as a third-party administrator to employers, which represent about 60% of the marketplace in the United States. So it would create some monopolistic problems that they couldn't overcome. You didn't read about that in the paper, but that was part of what was going on behind the scenes. The other thing is how big this employer market is. So Cheryl mentioned that she has members that are primarily the large end of the marketplace. We're talking what we call jumbo employers, which are 30, 40, 50 to a couple 100,000 employees, which translates into maybe 40, 50, or 500,000 lives. So a very substantial number of people that we're talking about in those kinds of plans. You also have municipalities and unions that are also covered in different ways, either through ERISA or through the Taft-Hartley Act. So when you start adding all that up, we have close to 100,000 plans that fall under this, what we call the employer space. And this little graph here, if you look at the blue, is the actual employers, so the businesses. The yellow is the municipalities, so city and state governments. And then the very tip, which is a little bit hard to see in this particular graph the way it is, in gray, is the unions. So the vast majority of what's out there in the marketplace, and that's been consistent, is the employer. You also notice from 2005 to 2015, the numbers increased. Remember the big debate during ACA was employers are going to get out of the market. The way the economics works, it's better for them to self-insure. So what we saw in the passage in 2010 is a big bump up to 2015, a very large growth in the number of self-insured plans. Almost 20,000 more plans came on the market in that 5-year period. So very substantial change. Now, the projection to 2020 was based on the existing ACA and the implementation of the rest of the components of ACA. Of course, now we have no idea what's going to happen. But the likelihood is that we're not going to see the decrease in the number of plans. We'll probably see more of a leveling in the number of plans. So employers still will represent a large number. So the success of where we're at today in the marketplace is likely to continue, even with all the disruption that we're seeing now with Trump. But when you drill it down to individual plans, looking at the purchaser, the payer, the provider, and the consumer as a patient, they're all feeling the pinch of what has changed as a result of ACA. It took time. It was passed in 2010, started the implementation in 2012, and we're still just now seeing some of the effects of the legislation pulling itself through the marketplace in late 2016 and now in 2017. So it's changing business models. It really hasn't been an access issue per se because of the number of different rules and requirements that were in the marketplace. But what it did begin to do is separate the distribution function and what was able to be commoditized from those things that really can't be commoditized. So things like drug distribution per se really is commoditized and will continue to be commoditized. So that means if you're in a pharmacy and you're selling drugs and that's how you make your money, the likelihood is you're going to be making less and less. That's what a commodity market's all about, drive the price down. On the other hand, if we look at specialty pharmacy, it's really positioned as a fad, and a fad that probably will be around, but it's probably going to become the norm, which is why it's a fad. And for some of the points that Cheryl pointed out, the number of FDA drug approvals, the economic claims behind the specialty pharmacy make it really the pharmacy marketplace. There's a lot of dichotomy in the marketplace around aspirations and understanding all the different implications, because not only healthcare is complex, but the relationships and the stakeholders that want to keep their piece of the pie also drive some of that. So a lot of things really don't make sense. So we look at drug tiering as an example in plan designs, or site of care, which is the SOC on this, are really symptoms of the problem that have existed in the system. They're really not some of the root causes. So if we were doing an academic exercise with a diagram, a fishbone diagram as an example, we would be working back to what's really the root cause behind why do we see tiering in site of care. So when we do analyses in the self-funded marketplace, this employer, and we look particularly at drugs, and we have to look not only at drugs, we have to look at devices and diagnostics. They're all kind of tied together when we talk about these specialty drugs. We have to understand that there's a lot of implications, not only as a purchaser of care, but also on the member who's the patient. So we're trying to look at that in what we call a holistic fashion. One of the problems out there is that the few reports that are out there, which are generally drug trend reports, are generally economically driven. So talking about what are the claims costs, what are the new products coming on the marketplace. But we don't really have good information that helps a employer who's a plan sponsor make good benefit decisions. A lot of them are proprietary reports, the CVS Caremark report, the ESI report, the PBMI report. All these PBM kind of reports are their reports, and they're telling you what they want you to know. So we don't have a lot of open source information or data. So just like if you do the evaluation of clinical literature, in here we have to look at, well, what's the perspective of the author and the intended audience? So they're trying to influence employers in this case, if there's a PBM report. Is it a marketing tool, or is it really objective information? Is it a one-off report on a topic, or is it really an issue-driven that somehow reflects what's going on in the marketplace, or is it just identifying here's a market trend, short-term, may only be around for a year because of some fluke in a law or regulation. So we have to be much more critical about accepting the information that's thrown out there Because what I see in all the literature, the little bit that does get out there around this, there's a lot of problems with interpretation. And when I get to review articles for publications, I've called out authors on that because they don't understand what they're looking at. They take it as gospel that this is the right information. So trend report limitations is the opportunity number one. Because I know Glenn does the hospital one with ASHP. I've been involved with a lot of trend reports over my career as well. But there's really nothing in this space. So Cheryl and I believe this is an opportunity to start looking at and having a dialogue on with Glenn and the rest of you, and particularly about longitudinal trend data is lacking because many of these reports year over year don't look at the same issues. So we don't know 3 years ago what was being adjusted for when we're reading it in 2017. They never addressed that. The other problem is that from an even economic perspective, they're not doing adjustments as well. So as they've played around with their formulary and their book of business changes in terms of who their clients are, we don't really know. And they just say, oh, we're just so big that it doesn't make a difference. Well, it does make a difference, and they're not adjusting for that at all. So actually, when all is said and done, the best reports that are out there are from the investment firms, the Wall Street people. They do phenomenal research. And so that's really what I look to. That's what I consider my gospel. They really do a great job. But they also have their own limitations. They talk to people like me who are in this business because they want to make sure they get it right because they're representing a fact to their clients who are making an investment. They have a fiduciary responsibility like Cheryl was talking about. So this whole aspect of fiduciary responsibility is a big deal. And that's something that we can do. So we want gaps closed around data, and we need more and better insights on a continuous basis. The fact that we've been doing this simple market trend survey for 5 years, nobody else in the market has done that. We're the only ones that have done that. And it's not that complicated, but nobody did it. And it gives you some insights, but we've got to build off of that. The 4 major drug categories that everybody talks about from an employer perspective when we go to meetings, in the cardiology space, in the diabetes space more specifically, in the endocrine category, immunology, and then oncology. So that's what we talk about a lot because that's what everybody talks to us about. Then we try and change the conversation because, again, it's more of a symptom rather than the root cause. So why design benefits? Employers don't take their fiduciary responsibility as seriously as they really need to, and so we're trying to remind them about that. Benefits do play a big role in compensation strategy, particularly these days around health insurance, because it's not inexpensive to have health insurance. So it could be an opportunity if you're hiring to get better and more qualified people to work for you. Because they are costly, you want to do planning, you want to be thinking through your plan design, because it gives you some efficiencies in your business. And it also allows you to optimize your tax advantages. There's significant reasons why that self-insurance market grew after ACA, because it was less costly to the employer to sponsor their own benefits rather than buy benefits. Design also promotes better coordination between the medical and pharmacy benefit, and specialty drugs is the poster child for why you have to do it. 50% is reimbursed under the medical benefit, 50% on the pharmacy benefit. So if you don't coordinate benefits, you're in big trouble as a plan sponsor. You have to manage both sides. And then finally, promoting and maintaining the plan has to be done not only because of ACA changes every year, but also because the market is changing. The market was changing before ACA. It then accelerated in different ways after ACA, and we're now seeing what I'm calling a rapid cycle change in the market because of what Trump's doing and stirring the pot so much. So we have a lot going on in the market across all the stakeholders, not just the employer. The whole idea of value-based benefit design, Cheryl and I have been involved with that for, 25 years, I guess? We're still talking about it. We're now in the second iteration of this. So there's a lot that had been done that was never remembered when we're looking at it today. So we're kind of the historical people talking about it. But there are opportunities to do better benefit designs, and that's really what it's about. So part of the reason is there wasn't enough marketplace disruption versus what we see today. We did have some in 2008 to 10 with the economic recession. So real market change was slowed because of some of these factors. The technology and innovation has accelerated, as well as applications of even old drugs. It's the same thing with devices and diagnostics. You're familiar with the printers, drug printers now? So there are, I think, 3 companies that have been approved for having bioprinters, so you can print drugs on demand. So what's the implication for that in pharmacy and benefit design? Nobody's even touched that, but it's been FDA approved already. They're ready to roll with it. So we have to look at that. And then what we've been talking about, healthcare reform, and now we're into, are we going to repeal, repair, and replace with what? So there's a lot going on right now. So I'll just take a moment on this, and then we'll move along because we're running out of time. So the evolution of value-based design is what this is about. And the idea here is talking about the level of complexity to achieve the nirvana of value-based design, where you're really getting the best and optimal outcomes. So low complexity is where the pharmacy piece is. High complexity is what we would call precision medicine today, but employee-specific benefit design. So if we went from a pharmacy benefit only, and pharmacy, like with computers, was the leader in value-based design, a lot was happening here. Specialty drugs now changes the dynamic. So we have to be moving further to the right. We have to get into this integrated drug and condition management. Otherwise, we'll never get to value-based design. And with the specificity now from the genetic testing, and even using gene therapy as a drug, we have to eventually, at some point, and this scares employers to death, getting to employee-specific benefit design. And nobody has thought about that either. So just within this one simple concept, all of a sudden, it's another whole set of more discussions that have to take place. So there's opportunities because of that, which is number 2 here, where we can start looking at transforming the market, and Cheryl kind of alluded to that. So how do we look at balancing or disrupting the current arrangement in the drug distribution channel as well as in the service channel? Part of risk, and this is an important insurance concept, we need metrics to start understanding that, because we've been shifting risk. It's not just the plan sponsor who has the risk now, but providers also are involved with sharing risk, if they're a hospital or a medical group, as an example. So what's the value proposition in that context, as well as what are the metrics that we're going to start looking at? And the metrics we have right now don't work. They're really not helpful at all. So we have to look better and more innovatively at metrics around outcomes. We can't do nothing. We need to start looking at different options, and this is really the third opportunity, which is right here. Looking at what could be the opportunity for a more useful and coherent metric. And it may come from other existing sources, such as Department of Labor has a metric. There's some economic measures that the CFO uses as well. There's no leadership happening in the marketplace right now, so it's open opportunity to try and do that and fill a void in the marketplace by providing some leadership around that. So that's the end of my presentation, or section of the presentation today. And I think we still have some time for some questions. And I know we covered a lot of material. You will have access to the slides. This is being taped, so you'll be able to see it as well. So any questions from the audience? Yes.
This has come up in a couple of conversations I've seen, I think in online webinars and in your discussion, things like that, is misalignment of incentives.
Yes.
So if you're looking at the system now and you're saying there's lack of transparency, or in the contracting terms, PBMs are declining because they say, oh, we don't need your business because we've got our other business and they're perfectly fine with the way we currently do things. That seems to point to the incentives aren't there for them to change.
Right.
So I would ask, from your perspective, from the employee-sponsored, self-insured perspective, where do you see the opportunities are to change that? Is it in getting all of your membership to sort of change their expectations of contracting? Is it in a legal change and a fiduciary responsibility change? Where do you see that sitting?
It's a really great question. And besides the shaming I mentioned earlier, I think that education is key because the vast majority of employers have no idea that this is going on. They just think the costs are what the costs are. The jumbo employers are trying to change this, and in general, they get their needs met. They get better pricing, much better pricing, and they'll get certain things integrated in the contract to make sure they're getting integrated reporting and things like that. But I think it's going to be initiatives like Randy and myself and our sister coalitions are working on that will start driving change in the market that will make the PBM start paying attention. You know, it's just like health plans or many other groups. Once somebody comes in with a new solution, you know, health plans never wanted to provide price transparency tools for the consumer until there were 10 or 15 vendors in the market, and now all health plans offer that. So it's not going to happen overnight, but trying new and different things that pulls them out of the loop is going to make them change over time. That's what I believe. I don't know if that answers your question.
Yeah, it does.
I mean, nobody's too big.
Yeah.
Is what you got to keep in mind. In these investment calls with these companies I talk with, I'll tell them I think ESI will be out of business in 3 to 5 years, as the way things are currently run. And ESI is a big company. They're all making a lot of money off that. And they used to laugh at me. Now they're not laughing. They see that possibility that ESI will not survive. So you have to start questioning everything and don't accept the status quo. And that's kind of what we're doing with the employer. Things like first fill. You're familiar with that, right? Initial fill. That's no big deal to us in the pharmacy world. That was huge in the employer world because they never thought of that. And none of the PBMs did it. And so we picked up on that and amplified it. So we're not going to take credit for it. But we pushed that message out. And within a year and a half, every PBM had it. And it became a differentiation. Every one of them was selling that as one of their key features. Oh, we do first fill.
One of the things that we don't want to have happen is that we create a new mechanism and it just creates a whole bunch of new middlemen.
Right, right.
You know? So,
Yeah, we don't want to replace the mess.
right. It's 1:20. We promised to be done at 1:20.
Well, we have a few more minutes.
Oh,
Yeah. So this is really, really interesting, and we're an academic college, but we're also associated with a medical center.
Right.
And we happen to have a specialty pharmacy here that is part of the medical center, but it's actually a division of the college. So we are integrated both in the college and in the medical center. And you talk about disruption and how you're seeking a disruptive innovation, which would be a strategy that could do more for less. And I think, I was really listening to hear if you would bring up health systems as part of the disruption, because
Yeah.
I think that you're looking, the model is the PBM health plan model, and a lot of these problems like site of care and things like that, an easy solution would be, well, we don't like what the health system is charging, so carve it out and put it with the PBM. Well, that's not disruptive. That's just creating another, then you're going to take your infusion business and make it look just like the take-home business.
Right.
And so the health systems now have about 10% of the specialty market. And they are, it's a very small number because patients on specialty medications end up getting referred to like a specialty health system. And so I just wanted to know, and I have a good case study of HMO Illinois and the city of Chicago, because we have, we're trying to disrupt the market as well.
Right.
And one of our biggest patient groups is city of Chicago, and they come here for all of their care. They get prescribed a specialty drug. They come to the specialty pharmacy. We can't fill it. It has to go to CVS Caremark.
Right.
And so we call HMO Illinois, and they tell us that we have to go to CVS Caremark
Right.
and ask to get put in that network. And we've made that request several times. Clearly, they turn us down every time.
They don't want you to fill the drug, they want to fill the drug and keep the money.
Right, but so I know you're talking about disruptive innovation, and so I really think health plans should be considered, or I'd like to hear at least what your thoughts are on that.
Well, it comes a little bit in pieces because it gets back to this root cause issue, which does take some time. But conceptually, if you look at what are some of the really key stakeholders, if you're really trying to get good outcomes from an employer perspective, not the I control your diabetes outcome necessarily, but does that then translate into good workforce? So there aren't that many key players when you start looking at it from that perspective. So there's a key role that the hospital health system as well as providers contribute. It's not in the distribution of the drug, it's in the clinical service. Right now, we don't pay for the clinical service is the problem because there's so much money on the drug side. So when we talk about disruption, we're talking about redistributing the dollars. And we're talking about 50 cents of every dollar is going to get redistributed, which is pretty disruptive. Because there's a lot of stakeholders that are going to say, oh my God, I'm going to lose 50 cents of every dollar. That's not what we're talking about. We're going to take the 50 cents that right now gets socked away where nobody knows where it's at to pay for those services that we know will contribute to the value-based health.
So why don't the employers start contracting directly with health systems?
Well, that's a
That's
possibility, right.
I mean, there's discussion of direct contracting with pharmaceutical manufacturers through entities like coalitions, because right now they can't do it directly because of the ironclad PBM contracts. Many of my sister coalitions, especially in small regions across the country, have direct contracting with provider groups and hospital systems, and they save a ton of money.
Right.
The reality, though, is that there's also a lot of, I'm going to use the word, abuse and misuse and waste by every stakeholder, including hospitals and providers and all of the other players. So there's going to have to be a tightening to keep employers in the game because they're the ones that are paying for the costs and the abuse.
And I'll take it to another extreme. Have you heard of on-site health clinics and health centers? So,
Driven by employers.
Right. So it's an employer-owned clinic space. Usually, if it's a manufacturer, it's on-site. Others will do a shared resource center. It may be a vendor. It could be the local hospital that's the vendor. It could be an employee of that company as well. But they have their own resources. And about 20% of the marketplace now, employers have their own on-site clinic. And what they report, not surprisingly, they're saving 50 cents of every dollar. Because they've eliminated every middleman in that case. So to Cheryl's point, hospitals have to realize they've got to change their business model as part of it. Yes, hospitals should be playing in it. Yes, physicians should be playing, pharmacists should be playing. But you got to change that business model. And that's going to take time because we're going to be redistributing so much of that economic wealth across the stakeholder population.
And I'll just add real quickly that for employers, attracting and retaining and keeping their employees healthy and productive is key. We represent a lot of manufacturing firms and they have to keep people on the line. And so having that on-site clinic not only prevents that person from taking the day, it's fine if they want to take a PTO day, but oftentimes they'll say, I'll be gone for a few hours and they never come back when they go to a doctor's office or something like that. So having it all available right there has provided real value. We know that this is a lot and lack of time, so if you guys have questions, share them with Glenn. You can get them to us, or our information is on our PowerPoint presentations. Was this helpful?
Yeah.
Good, good. Well, thanks so much for coming.
All right. Thanks.